Good morning, everyone. Am I audible and visible? All the centers and all the students, please confirm so we can start with the session. You can mention in the chat box if I'm audible and visible so I can proceed with the session. Okay. So let me start. Good morning, everyone. I hope all of you are doing good. So this is Dr. Sandeep Sharma here. I am pediatric faculty for NEET PG and FMG at Doc Tutorials. And this session is, it's a very different session. It's not related to directly your NEET PG or FMG or NEET super specialty kind of papers. This is related to your important thing, which everyone has to go through, especially if you are in final year. You will be sitting in your exam. Some of you are exam going, many of you are exam going, and you will be sitting for the exam in case of pediatrics. Theory part is something Juki everyone knows what are the key areas, and you logically most of you would have prepared for that. When it comes to practicals in pediatrics, it's a tricky area because history taking examination in pediatrics is a troublesome thing. It is always easy to convince a patient who's adult. It is slightly trickier to do it for a younger child. And so in this history taking an examination, ideal scenario would have been that I am sitting face to face with you. I have a patient in front of me and I am explaining on the patient. But in this age of social media, we need to adapt according to it. So I will keep the session very brief. 1.5 hours to 2 hours I will take. There is a small PDF kind of a thing, annotated PDF that I will be sharing. Some of you might have got it, those who have joined through various groups of tutorials. For those who have joined, who are directly watching this YouTube channel, once I am done with this, in case you still want the annotated PDF or the details of it, you're most welcome to ask about it. I will share in the relevant groups. But the point is, I will be discussing about the things which we often miss. It is not a replacement of your history taking or examination procedures on the bedside. It is something to help you in the actual exam, things you should not miss out on. It's more like rounding the edges. You are the diamond yourself. Your skill is your diamond. What I'm doing is only polishing it a bit. So they take it as a polishing session. And let me start with the session first of all. So this is my social media details. In case you have any doubts after the class, you can get back to me. You can share your comments and any additional things with me. So let us start with the prerequisites. So whenever you have a case, whenever you sit, you go to the clinics and you have an exam going on, you have a pediatric patient in front of you, you will have to go for certain prerequisites that you need to go in for. So what are the prerequisites that you will look out for in these patients? First of all, you should be properly dressed in the wards. It is very important that you are properly dressed. You look like a doctor. See, many of you, you would start to feel, sir, why should our dressing sense matter in a practical exam? It matters a lot. It shows you how sincere you are, and there is always a code of ethics. Being doctors, we are supposed to follow. So unless there is a religious reason, then if there is a religious reason, then it is fine. Medical reason, then it is fine. But otherwise, you should be clean. You should be wearing an apron, preferably with your name, roll number mentioned upon it. And you should be, if you're a girl, you should not have loose hair hanging around because you will be dealing with sick children. You will be dealing with patients. So you should be, tying your hair. In case you are a male, you should be clean shaven, unless if it is for religious purpose. And you should always be carrying the proper equipments with you. So be properly dressed is a prerequisite. This is something which is a logical thing. Ideally, I should not be telling this, but it is something that you must know from exam point of view. It is very important. A lot of examiners believe in the first impression being the last impression in the exam. Second is when you get a case, suppose you get a case of any acyanotic heart disease, first thing is introducing yourself to the parents of the child and building a rapport with the child. So always introduce yourself, talk about your designation, why you are here to take history. Tell them that I am a junior doctor who has been assigned your child's case. I will be discussing in detail and I will be presenting it to a senior doctor who will then give good decisions, and your child's treatment will be better. That way, you have to convince the parents and take consent from the parents. So you should always do it. I've seen a lot of residents, simply lot of interns, lot of final year students simply watching in, and the parents are doing something. They will not wish the parents. They will simply asking, "Kab se bacha bimar hai?" Don't do that. There is a way to proceed, and these things are going to matter. Sometimes examiners will ask the parents, "Did this doctor introduce himself? Do you know his name?" If the parents would say, "No, he never introduced to us," you are in a soup. ये छोटा चीज है, nobody will tell you, but please practice. So introduce yourself and build a rapport. The history you get will always be better, more reliable. Third thing is ensure an appropriate setting for the patient. When I say ensure appropriate setting, there are a few things that you should remember. First thing is always take history in a sitting position. So the parents of the child and the patient, they should be sitting. It's not like that you are sitting and they are standing and giving the history. This happens very often in wards. If examiner is passing through, they will scold you for this thing. So parents and patients should be comfortably sitting. You, the doctor, should be either sitting or you should be standing. And the question next arises is, where should you be sitting? The patient should always be on your left side. On your left side. So if I am standing on my left side, there should be patient. I should be standing patient ka right side, and my left side, the patient should be there. So patient should be on your left side. Thirdly, there should be adequate light in the room. So it should not be a dim lit room where you should be taking. There should be adequate light, so you can watch the child also while you're taking the history. At the same time, many of us are in the habit of, parents, you are taking the history and simultaneously you are poking the child. Don't poke a child till the examination findings come. And don't keep staring at the child. Do not frighten the child. Children are, this is where pediatrics differ from adults. In case of adult, the person knows that this particular doctor has come to take my history. If you are taking a history and constantly staring at the child may get uncomfortable and he will not allow you to perform examination. So don't stare at a child. Don't stare at the patient. At the same time, see all these points which I'm mentioning. Aap bolenge, sir, why are we discussing in a live class about this? Why are we not talking academics? These are very important and they will ensure a good history, and they will ensure that you don't falter where people will go wrong. I'm talking from a practical perspective. I've attended a lot of practicals, lot of histories. I've worked in multiple institutes, and this I'm telling from a personal experience. Examiners pay a lot of attention to all these small little things. End mein hame kya karna hai? We want to be a good clinician. We want to get a good history and examination, and we want to pass the exam. For that, these points will play a subtle role. So don't stare at the patient. Make the patient comfortable. Always smile at the patient. Then, very important thing, ask the parents gently. Ask the parents gently to switch off the mobile. This is again very important. And it is also important that you keep your mobile also silent. You are taking the history, ask the parents to switch off the mobile. Your own phone is having a ringtone of Justin Bieber, not going to work. So you should also practice. So ask the parents to switch off the mobile so that a proper atmosphere for the history taking is created there. After this appropriate setting, next we come to the sequence of history taking. So there are, to treat a patient, to make the diagnosis, you have three things in your armament. First is history, second is examination, and third are investigation. When you are sitting in the final MBBS, it is the history and examination that you are judged on. If your discussion goes to investigation and management part, by that time you are already pass or fail. It is only to test whether you should be getting a gold medal or not. So it is history and examination that decides your pass or fail in the practicals. Now there are short cases, there are long cases, types of cases, details I will be coming later. So what is the sequence of history taking in pediatrics? So there should be general information. Then we ask about chief complaints. This is how we present the case also. Then we talk about history of present illness. We talk about treatment history. We talk about past history, antenatal, natal, and postnatal history where relevant. Then we talk about development history, immunization history, dietary, family history. You should make a pedigree chart, and then the socioeconomic history. So depending upon, with some rare exceptions, some changes can be made. But in general, this is the sequence of history taking. This is the sequence how you present also in the exam. So let us talk initially about the general information. So what are the general information that you will be asking from the parents and also mentioning on the charts? So first of all, you will ask about the name of the patient, age, preferably date of birth should also be taken, because many times parents will be they will not be literate and they may give a wrong, year of birth to the child. They sometimes do. So ask for the date of birth and also mention the gender of the patient. And then you mention about the informant. Who is the informant? Who has given the history? It can be mother, it can be father, it can be some relative. Also comment upon the education status of the parents, till what they have studied and whether they are reliable or not. When I say reliable or not, you are not judging the character or the personality of the parents. All you are asking is that whether when these symptoms happen, is the informant truly attached to the child and was he truly available at that site or not? Suppose there is a seizure patient and it is a relative who's giving history who has only heard that the child got seizure. So here the informant will not be reliable. You have to mention it. On the other hand, mothers are always more reliable than any other relative, including father. That is a truth, irrespective of which part of country you are taking a history. And residence is also important, because residence will tell you what are the things that will be asked related to the child. What are the things that you should be taking? What are the endemic things that are relevant? So how you will be taking, how you will be presenting. Patient's name is Varun. Aged, it is a child aged 2 years. Resident of Kannur, Kerala. The child's informant is mother of the child. The mother's name is Gayatri Devi. She's educated till 10th standard and she's a reliable informant. The parents as well as the child reside at Kannur only. This is how your ideal general information should be. The more smoother you say, the better it is. Don't go into fine details. Don't go into which gully number. Don't go into that. You take demographic data, you take, but don't go into gully number or what is the landmark. Simply mention about the place, the city, and the state. That is more than sufficient in these cases, right? Now, what are the questions which can be asked in the exam? So first thing they can ask in Viva, immediately they will stop you. They can ask you, why did you ask for age in the patient? Why did you ask for age in the patient? We asked for age because certain diseases are more common in certain ages. For example, acute lymphoblastic leukemia, children will be seen below 10 years of age. So this is one example. They will ask you, examiner will ask you, then if it is a post-streptococcal glomerulonephritis as well as acute rheumatic fever, they will be present between 5 to 15-year age group, right? Patients with thalassemia and sickle cell anemia will usually manifest beyond 6 months of age. So if it is a below 6-month child, you will not think of thalassemia and sickle cell anemia being the causative agent for the anemia in the patient. And in case it is a protein energy malnutrition, severe protein energy malnutrition, the peak age for protein energy malnutrition is between 6 months to 5 years of age. These are the 4 examples of why age is important in the child and what are the relevant points. So these points which I will be writing on the side, they are the commonly asked Viva questions. So hum jo karenge, see, this session is going to be like a buffet. Buffet mein you have everything for everyone. So I'm talking about the practical points. I'm talking about the points which are there in your practical manuals. I'll talk about the points which are not there. I'll also talk about the sequence and I'll talk about the potential Viva points here, right? So keep listening to it. This will certainly play and this will certainly help you not only in pediatrics, but in certain other parts as well. This is the importance of, age. Second thing, you ask about the residence. Why did you ask about the residence? The parents will, the examiner will ask you, residence kyun pucha? Because certain diseases are endemic diseases. So they will ask you, give the example of endemic disease in India. In India, remember that patients who are having G6PD deficiency as well as thalassemia, it is very prevalent. It is more common in Punjab and upper parts, or you can say West Rajasthan. It does not mean that everyone in Punjab is having G6PD deficiency, but the prevalence is more common in these areas. At the same time, if you have sickle cell anemia patient, sickle cell anemia is endemic. It is more prevalent in places like Bihar, Odisha, Jharkhand, etc. So Bihar, Orissa, Jharkhand, sometimes Madhya Pradesh, some parts of West Bengal. So that parts, the central and eastern part of the country, not the northeast, but the eastern part of the country, sickle cell anemia is more prevalent. And examiners can ask about sickle cell anemia prevalence kahan hota hai, because if you are well versed in the recent budget also, the government of India has said that we will be making a sickle cell anemia Mukt Bharat. So sickle cell anemia is going to be an important topic for even in your vivas and even grand vivas in medicine as well as pediatrics, and it is going to be relevant for your entrance exam also. So sickle cell anemia padkar jana hai, don't miss out for your practicals. That is one thing that you can write. Third thing about the endemic diseases is they can ask you about any other endemic disorder. Certain places will have fluorosis, groundwater is contaminated. So that manifestations of fluorosis will be commonly found in those patients. So endemic goiter you will look out for. Endemic goiter will be prevalent in certain hilly areas where the iodine content is less, as well as you will find that in hilly areas, the chances of congenital heart disease like patent ductus arteriosus is more common. So PDA patient, hilly areas will be people living at high altitude, low oxygen concentration will not allow the ductus arteriosus to close, and that is why PDA will be more prevalent in these hilly areas. It will be more prevalent in these hilly areas, right? So this is the questions related to the general information that can be asked to you in the exam, right? Then we come to the chief complaints in the patient. So what are the things that we are going to discuss related to chief complaints? Now, when it comes to chief complaint, it is important that you ask about the chronology. Chronology in the patient is very, very important, that you start with the earliest thing which started and then you go systematically. Let me give, I'll give the example. So मैंने अभी example क्या दिया? Let us summarize the general information first. Raju, 2-year-old boy, resident of Kannur, parents also residing with the boy. The child's informant is mother of the child named Gayatri Devi. She is studied till 10th standard and she is a reliable informant. This is the general information that you will give, right? In 1 or 2 sentences. Then you will move to the chief complaint. The child has been admitted to the hospital or child has presented to hospital with complaints. What are the chief complaints the child has presented with? The child has been presented with chief complaints of 1, 2, 3, 4, whatever complaints you will say. The first complaint, which was the earliest complaint, you will mention first. And the most immediate complaint you will mention in the end in the patient, right? So chronology ka matlab kya hai? For example, the child has been having fever since 10 days, cough since 5 days, and the child has also developed a rash and lower limb weakness since 2 days. So what did I mention first? Fever, because wo sabse pehle start hua. So you mention the earliest thing first, and then you come to the more recent complaint. So that is what chronology is. Second thing is when to use since and when to use for. It is a very, very important point. People often interchangeably used. Many examiners are, obsessed with asking ki since kab use karna hai, for kab use karna hai. The point I'm going to tell you will be relevant even in your other clinical subjects. Since word hum tab use karte hain, we use the word since whenever a disease is still ongoing. Whenever a disease is still ongoing and it has been present for a quite significant duration. On the other hand, if a particular disease, the word for is used where the disease was present for a defined time, and it may or may not be ongoing. In case of since, no exact date is available. Here, some exact date may be present. Let me give you an example. It will be easier for you to understand. The child is symptom up. Parents will come with their child, and it is a patient of malnutrition who has been given to you. So you will ask the parents, the child's height and weight has not been increasing since what time? So the disease is still ongoing, but they don't know the exact date. So they will say the child is having poor gain of height and weight since last 6 months. Right? So यहाँ for नहीं लिखा हमने. We did not mention the word for. We said since 6 months. However, for जहां पर relatively defined time है, and it may or may not be ongoing. Second scenario, same child, I will say the child is malnutrition. वो हमारे पास आया. So what will be the chief complaint? Poor gain of weight and height since last 6 months. And the child has also had fever for 4 days, 10 days back. That is the reason why the parents came to medical attention. So there are two chief complaints here. Chronology we followed. Since was used where the disease is still ongoing. For word is used where the disease may or may not be ongoing, and for what time it was present, you may or may not mention it there. So the word since and for, many times it will be difficult to use. Many times they can be interchangeably used. But if it is an ongoing disease, always prefer the word since compared to for. It is a very controversial area, gray area. In the end, when I summarize, I'll give additional examples for this, right? So this is how we use since, and this is how we use for in the patient. Then another important thing that you need to understand is do not ask more than 4 chief complaints. Suppose there is a patient who's having 7, 8, 9 chief complaints. You pick and choose what are the 4, maximum 3 to 4 complaints which summarize the problem in the child. The child may be having headache. The child may be having cough. The child may be having running nose. But all of them will come under upper respiratory symptoms. So you don't need to mention all of them in chief complaint. You can mention them as associated complaints. So you can simply say, suppose there is a child with upper respiratory infection coming to you. So you will not write headaches since itne days, fever since itne days, and so on. You will simply say fever since 5 days. Since word use kiya because it is still going on. Child also has cough and other respiratory symptoms since 3 days. When you talk about history of present illness, then you will elaborate what are the other complaints. So you got my point. You will not go into too many details in the chief complaint. Fourth point, so this is done, this is done. Fourth thing, you will use the patient's language. Patient's own language is to be used. For example, parents already know the diagnosis. They will say, my child is having seizure disorder. So you will not say, child is having seizure disorder. You will say, patient said that there was a apparent seizure episode or convulsion episode. So use the patient's language. Do not apply your own technical skills here or technical words. They should be avoided. And if the number, suppose it is a discrete illness, child is admitted with vomiting. So if the number of episodes is more than 3, you will use the word multiple. Very important. I'll give you an example. Child having 2 episodes of vomiting, you will mention 2 episodes of vomiting were there. But if the child is having 6, 7 or 8 vomitings, you will not say 7 vomitings. You will say multiple episodes of vomiting in the last 2 days. So the word multiple is used when fever, seizure, vomiting, diarrhea, the episodes are more than 3. So you will say multiple loose stools in the chief complaint. How many loose stool? Detail aega history of present illness ke upar. So chief complaint, I'll summarize. Chronology, since for a thing which is still ongoing, do not use multiple chief complaint. Maximum 2 to 3 chief complaints should be there. Use the patient's language, no technical thing. And if it is an episodic illness, number of episodes is more than 3, the word multiple should be used. Exact number should be mentioned in the history of present illness. So this is the second thing related to chief complaints that I wanted to emphasize. Let us move further and talk about history of present illness. Now, history of present illness, when you start, in history of present illness, you will again go chronologically. So the first complaint which you started, which you mentioned in the chief complaint, now you will elaborate upon it. When you elaborate upon these chief complaints, what are the things that you will be mentioning? First of all, you will be, each symptom and complaint, you will be mentioning about the time of onset. So when did it start? when did it start? So you will mention the exact duration of the illness. You will mention about the duration of the illness in the patient, right? Second thing, in history of present illness, you will ask about the mode of onset. Mode of onset means whether it was acute illness, whether it was acute episode, whether it is subacute, whether it is insidious in nature, slowly increasing, or it is chronic. If it is a fever-like illness, so it will be acute. If the illness has been there for 3 to 6 weeks, there is no cutoff here. You need to understand it will vary from disease to disease. So if it is about few weeks, so we will call it as subacute. Patients with tuberculosis, you will call it as insidious onset of fever and progressive shortness of breath. So insidious will be there, and chronic will be used where the patient already has a chronic condition. The patient may have an underlying heart disease or a known patient of nephrotic syndrome or known patient of renal failure. So mode of onset you need to mention here based upon the illness. Then duration of the illness and consistency is important. When we say duration, time of onset agar alag se mention kiya, then you can start there also, or duration can be mentioned separately also. If it is already mentioned there, don't repeat it here. Consistency, when I say consistency, you need to mention whether it is intermittent in nature or it is continuous. If it is intermittent, it will also be called as episodic. So intermittent, that is episodic, versus continuous, you need to mention. Then frequency, you will ask about the progression and evolution, whether it is progressively improving with time or it is worsening with time. For example, if there is a fever which initially was high grade and now it is improving, you will think of a viral infection which is probably self-resolving. On the other hand, if the patient is having a weight loss which is now worsening, you will think of a likely malignancy in the patient, right? So progression and evolution also you need to mention. Then you will ask about any aggravating and relieving factors. So a lot of conditions will have their relieving factors. You will ask about diurnal variation. Typical example of a diurnal variation which examiners are fond of asking, they will ask about evening rise in temperature. Evening rise in temperature. What is the condition which is associated with evening rise in temperature? What is your answer? I'm looking at the comment box. Which is the condition where there is evening rise in temperature? Very frequently asked. Evening rise in temperature. I'm waiting for your response. What will you suspect? There is a patient having evening rise in temperature. What will you suspect in the patient? Sibin Thomas is the first one to answer. Yes. Excellent, Sibin. DC, excellent. It is tuberculosis. Real life, we don't see it very often, but examiners are very fond of asking that evening rise in temperature. Most of you are asking it correctly. Absolutely right. And you will also mention about any response to therapy in the patient, which has been mentioned, right? So any response to therapy related to the chief whatever complaint has been there. And then you should ask for any appropriate negative history. When I say appropriate negative history, see, lymphomas usually will not have evening rise in temperature, or for the simple reason, agar aap books ko dekhen, so they mention lymphoma as one, but lymphoma should be the second possibility. If they ask you the most important thing, first thing to mention is TB. Second thing you mention in lymphoma, you need to understand that fever is often present in most cases of TB. However, lymphomas, fever is not usually the presenting feature. It is usually present as a constitutional symptom, but it is low grade and often missed. So that particular diurnal variation, it is described in Western population, but in Indian context, evening rise in temperature in lymphoma, it is mentioned in various textbooks. It is not classically seen. तो आपका आंसर होना चाहिए टीबी. If examiner still pushes you कि कोई और बताओ, then the answer will be lymphoma. But don't mention lymphoma first instead of tuberculosis, right? But it's a good thing. Most of you know the context of this. Take appropriate negative history. Appropriate negative history comes with practice. When I say appropriate negative history, I will give you an example. There is a patient who's having, child has been admitted with fever since 2 days, cough and nasal discharge since 1 day. So in this patient, you will explain in details about the fever. You will explain in detail about the respiratory symptom, but you will not mention on no history of any weight loss or loss of appetite. For the simple reason, the child is otherwise fine. If the examiner asks you कि क्या आपने पूछा, then you will mention it, but you will not mention in details and go for burning micturition at all, because it is an acute illness. So it should be an appropriate history related to that you should be asking. If there is a history of fever for 7 days or fever for 10 days, then you will ask for history of burning micturition also, where localization is not present. So it is a thing which comes with art. You learn with time, and in any chronic illness, you will always ask for progressive loss in weight and appetite. So appropriate negative history needs to be taken. In a patient of development history, do not go in details of respiratory symptom like no cough, no coryza. I'll give you an example. A child has been admitted with developmental delay since 1 year, right? So you will mention about the developmental delay and all. Apart from that, when it comes to respiratory symptoms, you will simply say no history of respiratory symptom. You will not go into detail of no history of cough, no history of nasal discharge, no history of noisy breathing. That has to be summarized and mentioned in one line. So appropriate negative history needs to be mentioned, summarized. Whatever system is involved, likely involved, that details, other systems, one line summarize that it is not involved. So no respiratory symptom, no cardiovascular symptom. Examiner asks you what symptoms you ask for, then you go into the details, right? Then we come to the treatment history in the patient. When it comes to treatment history, there are a few points that you need to mention. What was the treatment taken? What was the type of treatment which was taken? First, you need to mention the type. You can have multiple types of treatment. In Western textbooks, तो आपको standard पता है कि they are always they're mostly using the allopathic medicine. But in India, you have various methods of medications which are used. So allopathic use किया था, Ayurvedic was used, homeopathic was used, any Unani medicine was used, Ayush system, or it was a traditional system of medicine. Many times in rural areas, you have the traditional system of medicine also. So you will mention about the type of treatment taken. You will mention about the drugs which have been taken, for what duration they have been taken, whether they have been prescribed by a doctor or they have been self-administered. Many times patients will themselves Google and then take the medication. So the dose may not be proper in these cases. So you need to mention about treatment, history, type, drugs taken, duration, prescribed or self-administered, and lastly, what is the response to therapy. You will mention response to therapy in the present, that part, history of present illness also, and you will mention in the treatment history also. Examiners are fond of asking. So all these points which I'm writing, even if they are negative, you are supposed to tell them. For appropriate negative history also, there are marks that you get. The examiner does not pass or fail you randomly. There are marks for every step, everything that is being asked. So they cross-check with the patient also sometimes. So treatment history, these are the points that you will be asking for. Then you will ask about the past history. Past history, when you ask, you will ask about the past history in the child of similar complaints. You will ask for any past history of hospitalization. You will ask for any past history of any surgery being done in the patient. You will ask for any surgery done in the patient, right? So these are the past histories that will be relevant to the patient. For example, there is a child who has now come to you with features of congestive cardiac failure. Now you're thinking of CCF in the patient, but if there is a history of joint pains, sore throat, rash appearing on the body a few years back, you will think that probably the child had rheumatic fever in the past, and now the child is having a rheumatic heart disease manifesting as valvular involvement leading to CCF in the patient. So appropriate past history needs not be missed here. Because if it is a rheumatic heart disease patient and you don't mention about fever, arthralgias, etc. in the past, this is a major error and examiner is going to catch hold of you. Don't create history, but mention that there is no similar history of agar wo hoga to mention it. If it is not there, still mention that there is no history. So examiner will ask you, why did you take? You will say, sir, because it is the child is having pedal edema and all these respiratory problems. So I'm thinking of a heart disease. And so I'm just ruling out rheumatic fever in the past of the patient, right? Then antenatal, natal, postnatal history. Whether to take or not. Now, this is important. What are the points that you should remember? In case if it is a child aged more than 2 years and it is not a CNS case or a developmental delay case, in these patients, you will mention in 1 to 2 lines. Antenatal period was normal in the child, natal history was uneventful, APGAR scores were normal, and postnatally there were no immediate complaint. That's all. If the age of the child is less than 1 year, or it is a CNS or developmental delay case, 1 to 2 year mein kya karenge? That will vary from child to child, right? So less than 1 year CNS case, go into the details of these history. When I say detailed, in antenatal history, you will ask about the trimester-wise history. First trimester, what was the gravida para in the mother, just like you take for OBG. Then you will go into the details of any fever with rash in first trimester. You will ask about teratogen exposure, radiation exposure, quickening happened at what time in second trimester, third trimester, how many ultrasounds were done, overall how many visits were there, whether any abnormality was detected or not. So you will take trimester-wise history. Natal history, you will go details. You will ask about whether it was a spontaneous onset of labor or it was induced, where did the delivery happen, if it was cesarean, what were the indications, and whether the child cried at birth, APGAR score, and any immediate intervention needed during that time or not. And thirdly, postnatal history, you will ask about any jaundice in the first week, any immunization immediately given to the child or not, whether child required hospitalization for a few days or observation in nursery or ICU for some time or not. So postnatal also details you need to be taken. So when to mention in 1 to 2 lines, when to go into details, very, very, very important. So don't unnecessarily take history and in a 10-year-old child about antenatal, natal, postnatal. Child has come to you with fever and rash, 7-year, 8-year-old child, no need to go into the antenatal, natal, postnatal. Mention it. You need to mention, you get credit for that, but just mention in 1 to 2 lines. Young child, 7-month child, you need to go into the details of the case. Coming to development history, again, it is an art. If it is a CNS case, you will go into the details and you will mention all the milestones in 4 domains. When I say 4 domains, you will mention in gross motor, you will mention in fine motor, you will mention in language, and you will mention in personal, social, or cognitive milestones, right? And in all these domains, what you will mention what was the age of attainment of major milestones, sare nahi, but major milestones, and what was the last milestone attained at what age, and whether it is appropriate or not. I'll give you an example. There is a developmental delay case, or there is a patient who's having a CNS case, and you are taking the details of history. So how would I take history in the patient? I will mention, sir, developmental history I've taken in details. Gross motor milestones appear to be normal, with the last milestone being attained was sitting with support, which came appropriately at 6 months, right? So if examiner asks you what were the other milestones you asked for, you will mention there. Then you will say, sir, fine motor, these were the milestone. Language, these were the milestone. However, sir, social milestones are not appropriate. The child at 7 months, stranger anxiety should have come, but it has still not started. Also, the child is not laughing or playing with the mirror image. So there is a social cognitive milestone delay present in the patient. So you have talked about 4 domains: age of attainment of major milestone, last milestone attained at what age, and whether the child is having appropriate or not. If more than 2 domains are affected, we say it is if there are more than 2 domains which are significantly affected, we say global developmental delay. Otherwise, you say isolated language delay, isolated social cognitive delay, isolated fine motor delay, and so on. Gross motor, basically cruise movements control करता है, fine motor controls your fine movements of hands and feet, language is related to verbal output, social is related to the behavior of the child. And another important point, examiner may ask you, you can write it down also, which type of isolated mild delay is very common in Indian children. Remember that isolated language delay by a few months is common in male Indian children. We do not know the reason for that. This is something you will not find in textbooks, but my HOD was very fond of asking this question, and I've seen certain examiners from Delhi colleges, if they happen to come to your university for your exam, they also ask in details about it, right? So they are fond of asking things related to this. It will eventually come down to examiner's preference, but if they ask कि isolated delay किस domain में common है, remember isolated language delay by a few months, not very significant, but a few months is common in Indian children, particularly males. तो male बच्चों जो होते हैं थोड़ा सा language milestone delay हो सकता है, but if it is significantly delayed, then obviously, and when you talk about significant delay, there is a thing in OPGHI known as red flag signs. What are the red flag signs? वो table है OPGHI का. Please go through it once if you are getting a case related to milestone. Read it, memorize it, make it a part of your working memory. Here the Viva points may be asked related to the red flag sign in the patient, right? Let us move further, talk about the immunization history. When you talk about immunization history, you will mention about according to National Immunization Schedule. Do not quote IAP schedule in exam. Very important. When someone is taking history in MD medicine or MD pediatrics time, so post graduation mein you mention about the different vaccination schedule, but in MBBS final prof only mention according to National Immunization Schedule. According to National Immunization Schedule, you will mention there will be two possibilities. You will say the child is immunized for age, and last vaccine was this and this taken at this age. You need to mention about the last vaccine taken. So 9-month child, you will say the child's immunized for age, and last week the child has been given MR vaccine at 9 months of age. He has also been given vitamin A supplementation. So you will say the child is immunized for age. Many times parents will say the child is immunized for age, but the vaccination card will not be there. So when they say immunized for age and last vaccine taken, you will also mention. However, it is based upon the history of the patient. The vaccination card is not available. You will mention it to the examiner, because many times parents will say कि हाँ लगा है सब injection लगा है, but they might have missed out. So your reliability in that case will be slightly less, and you need to mention it there. And third will be if the patient is partially immunized or unimmunized, you will mention it there. And whenever you mention it here, your entire Viva will go on the vaccination. Many times I've seen Vivas end, the entire history end in the immunization history only. The examiner simply in the end asks, "Acha case kya hai?" They will ask 2 questions and go away. So immunization history, be ready with your all the current schedule and the vaccine schedule that you need to follow. Then we come to dietary and nutritional history. Dietary and nutritional history is tricky. In case, when you take dietary and nutritional history, most of the children that you will be taking a case, they will have some degree of malnutrition. You have to ask about the diet taken in the last 24 hours. You will ask the mother, what was the diet child had taken in the last 24 hours? Or if it is the child has been admitted for 3-4 days, before admission, whatever is feasible in the patient. Before child got ill and was admitted, usse pehle, what was the diet child was taking? You will start from the morning when the child gets up. You will include the snacks in between, all the fast food, everything, and go till the dinner time. And whether post dinner the child is consuming anything or not. You will roughly calculate calories in the child, roughly calculate proteins in the child, and you will mention whether they are appropriate or not. And for this, you need to have ICMR calorie chart. It is freely available. You can Google it also, download the latest one. The latest one came in 2018-19. That ICMR calorie chart, that help can be taken. It can be carried in the wards, but ideally you should be reading briefly about it so that the common foods in your areas. For example, if you are in Kerala or in Tamil Nadu, then you should be knowing about the wheat. You should be knowing about the rice and just simple wheat chapati, what is the calorie content in that. But if you are in the northern part of the country, then rice, the types of wheat, whole wheat, bran wheat, and the type of rotis they are making, size of the roti, and calories correspondingly, slightly more details will be asked. So according to the part of the country and the diet being followed there, you need to, remember the major values over there. And always remember that ideally exact calorie requirement you will not be able to calculate. You need to come to a broad conclusion whether the patient is having calorie deficiency or protein deficiency or not. And here you should also know the age-wise calorie and protein requirement. Again, in the calorie chart, it is mentioned there. So this is something that you will have to, this is, I cannot discuss in this only 2-hour class that I have been given here, but in case you find any difficulty, you can let me know and we can discuss in detail. So diet in the last 24 hours, how many calories, how many proteins, appropriate or not. And also in dietary history, if the age of the child was less than 5 years, also mention about breastfeeding. How many times the child was breastfed, till what age the child was breastfed, when did weaning started, complementary feed was introduced at what age, and still the child is on breastfeed or not. That you need to mention below 5 years of age. If it is a 12-year-old boy, you will not talk about breastfeeding, right? It is understood that you are not supposed to talk about it. So, but less than 5 years of age, mention breastfeeding details also. Do not miss it. I'm putting a star. Now, moving further, we will be talking about the family history in the patient. When you take family history, ask about similar complaints in the family. You will ask about family history of contact with tuberculosis. You will ask about any family history of diabetes mellitus, hypertension, any smoking in the patient, smoking in the family. Because even if a father is smoking, passive smoking can cause or worsen or precipitate respiratory symptoms in the child. They can also induce malignancies in the child also. And also in family history, you will ask about you will make a pedigree chart. So pedigree chart, making like this, and how many patients are there, how many things are there, and who's affected, you will be mentioning and labeling it here. In case of a CNS case, in CNS case, 3-generation chart, because you need to look at the type of inheritance in generation pedigree chart. Otherwise, a 2-generation chart like this is also more than enough. It is also TB, DM, hypertension, smoking. Also, if it is a respiratory case or asthma case or a bronchiolitis case, respiratory bronchial asthma in the family. Because these tend to be associated together in most of these patients, these things, whether they are present in the patient or not. Now, moving further, we will talk about the socioeconomic history. We'll ask about, we will utilize the modified Kuppu-Swamy classification. 3 parameters are used. The 3 parameters very frequently asked in Viva exams. You will ask about education of head of family, you will ask about occupation of head of family, and the total family monthly income as well. And total family monthly income keeps on changing every year. So you will always download, carry the data with you. The latest data should be used. However, based upon this, the total score is calculated and the socioeconomic classes, they remain the same irrespective of data. So this interpretation can often be asked in your Viva exams as well. If it is a patient of protein energy malnutrition or rheumatic fever, there is a strong correlation with low socioeconomic status, and that is why the parents, the examiner may ask slightly more details. Where the child is staying, how many members are there in the family, how many number of rooms are there, well ventilated or not. So if it is an appropriate case, you will ask about it. But unless the examiner asks the details, you will not mention during uh, the history presentation, right? So this is the history taking that you will be doing. So I will summarize. The sequence will be same. So you will be starting with chronologically the initial data you will mention and demographic data. You will talk about the informant status. You will talk about residence of the child. Then you will take chief complaint mentioned in chronological order, history of present illness. You explain the chief complaint in details, 7 or 8 points, aggravating, relieving factor, progression, since when it started, what is the current status, etc. The appropriate negative history will be taken, and then the relevant histories according to age wise, according to system wise, you will be taking, right? And summary of history is very important. When I say summary of history, examiner will ask you, always keep it ready before. Many students, what they do is immediately after taking history, they jump to examination, but they don't keep the summary of history. And when the examiner asks you, sometimes your roll number is last and examiner is in hurry of catching a flight or train after your exam. He is supposed to leave. So he will not have 20 minutes to discuss with you. He will take your, so he will simply ask you, start with the history. You start with the history. When you give a summary, you should be summarizing the complaints in the patient. How you will summarize? Sir, this is Raju, 5-year-old, a resident of Kannur, who has been admitted with chief complaints of fever since 5 days and upper respiratory symptoms since 3 days. There is no other appropriate negative history. The developmental history, immunization history, feeding history in the child is normal, and there is no family history in the patient. However, the child has father who's a smoker. That is how you are going to summarize. So all the relevant points in 3 or 4 sentences I have summarized. Then they will ask you analysis and provisional diagnosis based upon history. Analysis and provisional diagnosis based upon history. When you talk about it, then you need to mention which system is involved. So you will say, sir, likely this child is having the involvement of respiratory symptom, predominant respiratory symptoms along with constitutional symptoms like fever are there. You will mention about the nature of the disease process. Since the disease is present only since last 5 or 7 days, you will say it is likely to be acute illness. And broad etiology, sir, likely to be infectious. Why? Because fever is present and there is no other history relevant to the case. And associated features, you will mention if the child you suspect is also having malnutrition, you will also mention that how, in addition to this, the child also has calorie and protein deficient. So there may be some element of malnutrition as well. So summary of history and analysis ek jaisa lagta hai, but they are not the same. I will explain again. Summary of history is summarizing the key points. Analysis and provisional history diagnosis is you analyzing the content and telling what system is involved. It is acute, chronic, or insidious in nature. What is the type of illness we are dealing with? It is a congenital infection, it is a genetic problem, it is infectious condition, it is a malignancy, and you will talk about any associated features like malnutrition, like any allergies present in the patient, right? So this is analysis. Summary and history, these are the areas where most students falter. If you give it properly, with confidence, appropriately, most students will pass at this level itself. Trust me. Yes, they will pass at this level itself. Examination finding, examiner will just test you the broad contours. So this is the first part. In exact 1 hour, I've finished with the history taking things that you will be discussing. Another 5-7 minutes, I will be focusing on the common cases and history points not to miss. And what is their interpretation that you should be taking. See, every case you need to ask about positive complaints, negative complaint, and they will vary from patient to patient. What are the things that you should not miss out on? If you get a cardiovascular case, if you get a CVS case in the patient, and it is a acyanotic case, the 2 acyanotic cases which can be given to you are ASD and BSD, right? Remember that ASD patients will be usually asymptomatic. Asymptomatic. So you will not mention any heart disease in the patient. You can say, sir, the patient has been treated for another illness and
examination at that place, he was suspected to have a heart disease. So examiner can then ask you, what is the heart disease which can be asymptomatic and in this illness? So you will say, sir, ASD, but ASD patient will not be admitted alone. He will have some problem or complication for which he is admitted. So ASD patients are usually asymptomatic. So don't say it is a ASD patient based upon history itself. It is a catch. Don't filter. Otherwise, examiner will come to know कि आपने file पढ़ लिया है, and that is why you are saying it, right? So ASD will be asymptomatic. In case of VSD, patients, they will have some common complaints. There is poor weight gain and poor height gain in the patient. So that history needs to, that will be a point in favor of this. Second thing you will ask in VSD is you will take history of feeding difficulties. Very, very important. I'm putting a star. History of feeding difficulties. Feeding difficulties, why? Because children with VSD, they usually become symptomatic around 6 to 8 weeks of age. And first 6 to 8 months of life, they will have feeding difficulties. They will have sweating on forehead while feeding. They will have sweating on forehead while feeding. They will have to make effort during feeding. So sweating on forehead while feeding will be there. And these children will also have suck, rest, suck cycle. What it means is the child will feed from the breast for some time, then he will take a pause. Then he will feed for some time, he will take a pause. Then he will feed for some time, he will take a pause. Because he gets dyspnea. Both of them, if they are mentioned, they indicate CCF in the patient. They indicate possibly CCF in the patient. So it is a significant VSD we are dealing, right? So malnutrition, poor weight gain, poor height gain being present, feeding difficulties being present, it is a significant VSD. You will not say VSD. You will simply say likely acyanotic heart disease in the patient. Likely CCF features are there. So in summary, please mention, in summary, do not mention the word ASD or VSD. Simply mention it is a acyanotic disease. Likely left to right shunt. Likely left to right shunt. You don't mention the word VSD or ASD, but these are the usually presentations of these patients that you need to ask for, right? And third thing, VSD patients, because of increased pulmonary blood flow and pulmonary plethora, you may or may not have history of frequent chest infections. So frequent chest infection history may or may not be there. These are the points that you will be looking out for in history. They will be pointers telling you that it is a VSD. But in summary, don't mention VSD. Always say acyanotic patient. Likely left to right shunt. Agar examiner पूछे कौन सा होता है, then you can say, sir, VSD could be there, but I cannot say till I have examined, till I have investigated the patient, right? So this is the first thing related to the acyanotic cases. Suppose you get a cyanotic heart disease case. So it will be usually a tetralogy of fallow patient. So tetralogy of fallow patient will be there. In such a patient, always ask about history of bluish discoloration. You will ask about history of bluish discoloration in the patient. There is some connectivity issue I'm just getting. Just let me know if the voice has improved or not. Sometimes there is a dip. Am I audible and visible now? Just confirm once. Am I audible and visible? Please confirm in the comments. Please confirm in the comments. Okay, I'm visible now. Okay, voice is coming. Fine. Thank you. Thank you. So we continue. So if you get a cyanotic case, you get a tetralogy of fallow case, you will ask about history of bluish discoloration. When you mention history of bluish discoloration, always mention that where it is present, because central discoloration in the lips and oral mucosa will indicate a likely cardiac or pulmonary disease, whereas peripheral can be seen in benign conditions as well. It can be seen in benign conditions as well, right? So where it is present, secondly, since when it is present, and whether it, when does it worsen, and whether it is relieved by squatting or not. Why are we asking these complaints? Because if it is a tetralogy of fellow patient, it will start from 4 to 6 weeks of age, and it will progressively increase in nature. It will worsen when the child is having a spell in the patient. So we call it as a cyanotic spell. We call it as a cyanotic or TET spell. When the child is having crying, it will worsen. When the child is having cough, it will worsen. And it will improve when you put the child in squatting position. It will improve in squatting position. Squatting position is putting the child in knee chest position, bringing the sweating is a position that is a common maneuver. During exercise also, you can make the child sit. So those who are thinking what is squatting position, the early morning position you take, Indian style, that is squatting position, right? So it will improve because the squatting position, the right to left shunt tends to fall, right? So these are the things that are relevant to tetralogy of Fallot. So that is why you will be taking these histories. In addition, because it is a cyanotic disease, so they always ask about history of poor gain of weight and height here also. Poor gain of height and weight here also. See, acyanotic patient में poor gain of height and weight क्यों हो रहा है? Because of CCF and feeding difficulty. But here poor gain of height and weight is happening because it is a cyanotic disease. Because of cyanosis, because of hypoxia, the tissues are not growing well. They are not getting enough oxygen. So here also poor gain of height and weight will be present. And also you will ask for any complications in the patient in the history itself. How you will ask for complication? What are the complications of tetralogy of Fallot? You will ask for any history of any limb weakness. Why will any limb weakness happen? It may indicate stroke due to embolism in the patient. Chances of paradoxical embolism is high in tetralogy of Fallot. You will ask about any history of fever with seizures in the patient. Why? Because there is a chances of brain abscess developing in the patient. So these are the two specific complaints you will ask for during complications in the history itself. So in cyanotic cases, always look for these points. So these are the pointers which you are going to mention, whether they are present or not. They will help you in supporting your diagnosis during history taking. If you have a renal case, you can have two common renal cases given in the exam. Either it will be a nephrotic or it is a nephritic syndrome case. Nephrotic syndrome case, usually the child will have onset of symptoms more than 2 years, and the child will have progressive swelling of the body. Progressive swelling of the body. So this progressive swelling will be classically starting on the face, especially in the periorbital region. So periorbital puffiness will be there. Then it will be progressing and involving the whole body. It will be more in the morning hours. Some patients, plus minus, they may have oliguria. So we will ask about oliguria. They will have no hematuria in vast majority of these patients. So you will not say hematuria, you will say dark or red colored urine. That will be absent. So this will be supportive of nephrotic syndrome in the patient. Typical example, let me explain. Chief complaints in the child. The child is having generalized swelling all over the body, especially face, since last 1 week. History of present illness. Child was apparently fine 3 weeks back or 2 weeks back, when the parents noticed the child is having generalized swelling of the body. The swelling initially started on the face. It appeared in periorbital region, was more in the morning hours. Over the next 2 weeks, the swelling gradually worsened and it involved the whole body of the child. There is no feature suggestive of poor urine output. There is no feature suggestive of any dark urine being passed. The child does not have any other associated symptoms like increased frequency or burning micturition. The child does not have any fever episode. The child does not have any other respiratory or GI complaints as well. Now, based upon this history, what is coming in your mind? Nephrotic syndrome. Why nephrotic syndrome? Because आपका no hematuria, no oliguria, no other system involved. Progressive swelling hai, first appeared on the face, later involved the whole body. This is the classic case that you will get nephrotic syndrome. Every third or fourth person in a ward in final exam will get nephrotic case. So nephrotic case is the best case to pass. If you falter in that, that is not my fault, but it is the best case to pass. It is the best case to pass. Examiner कई बार क्या पूछेगा? आपसे पूछेगा कौन सा केस लेना चाहते हो? Sometimes your senior resident or registrar in the hospital will be friendly to you. So he or she may ask you कौन सा केस लेना है? Never deliberately ask for a cardiovascular case. Never deliberately ask for a CNS case. Never deliberately ask for a protein energy malnutrition case. You get it, that's fine. But don't ask for it by yourself, because these three cases, the viva goes deeper and there are a lot of controversial things that are asked in the exam. CNS, you are very thorough with the CNS examination. You have confidence in your ability, go for it. But in case you have you're not very confident of performing the science, you can, take a call not to go. Nephrotic syndrome, easiest to pass because the history will be classic, the examination findings will be classic, and how you are going to manage the entire discussion and treatment part will be theoretical. Will be very similar to what you have already read in the paper. Maximum, the child will be having ascites, so they will ask you, how will you look for ascites? What are the signs to perform in examination on ascites? So the typical findings that you do, the shifting dullness sign, and if it is an older child or it is less ascites, the puddle sign, etc. Those are the things that you will have to perform. So it is an easy case to pass. Nephrotic syndrome, pass rate is always high. But again, most of us do not get the opportunity. We do not get the choice. So whatever you get, make the best use of it. Now, regarding to acute nephritic syndrome, in acute nephritic syndrome, the history will be very typical. There will be initial fever along with URI symptoms or a skin rash in the patient. And then about 1 to 3 weeks later, the child will develop generalized swelling in the body. Similar to nephrotic, but it may not be that severe. The child will develop reduced urine output. So oliguria history will be there, so it will be positive. And the child will also have dark or red colored urine being passed. So you have oliguria, edema, and you have hematuria, oliguria, and edema happening in the patient. Likely diagnosis is going to be acute nephritic syndrome. And examiner here may ask you what acute nephritic syndrome or glomerulonephritis, what is the most common cause? It is often infection associated in Indian children. Which is the most common infection? It is post-streptococcal glomerulonephritis. They will have fever and URI or skin rash, followed by 1 to 3 weeks later. This is the complaint. How you will mention in the history? History kaisa hoga? Sample history I'm telling you. This child, chief complaints. The child has been admitted for generalized swelling, dark colored urine, and reduced urine output since last 1 week. Since last 1 week, matlab abhi chal raha hai. In history of present illness, you will talk about these complaints and you will mention 3 weeks back, there was a preceding history of fever and upper respiratory illness, which resolved spontaneously. So now you have a supporting evidence कि पहले कोई पीछे हुआ था, उसके लिए the child was not admitted. अभी child क्यों आया? He is admitted for this. So this will not come in chief complaint. Unless this is the reason why parents have presented, this will come in chief complaint. Got it? So ये जो video है, there is a reason why I have taken on YouTube, because it will go up on the YouTube. If it was a Zoom session alone, many of you would not be able to, watch it again. So 2x speed karke, once you are reading the cases, just go through it once again, annotate in your existing notes so that you don't miss out on these points. So acute nephritic syndrome, there will be a precipitating feature, there may not be a precipitating feature. If it is a precipitating feature present, you do not include it in chief complaint, but you mention in the history of present illness that these symptoms were preceded some weeks back by these complaints. However, they were managed at home and the child did not seek, the parents did not seek hospitalization for that purpose. That will keep it very clear, crisp, and the examiner will also know what is the direction the history is going to, right? Next, we will, and in acute nephritic syndrome, you also need to ask for any, here in these patients, past history is also relevant. Past history is relevant because many patients can have acute nephritic syndrome or recurrent hematuria as a manifestation of Alport syndrome. So why you ask for past history? Alport syndrome, you will ask for because Alport syndrome can be a cause for similar illness of acute nephritic syndrome. It will be more, episodic hematuria happening in the patient. Swelling part is usually less, and they will also have eye involvement and sensory neural hearing loss also present in the patient. Now, when you get a CNS case, if you get a developmental delay or regression case, always start from when noticed by the parents. Always start from when noticed. Then you talk about progression. And here you go into the details of developmental history. Details of developmental history in the history of present illness itself. Very, very important. The details of developmental history, every point you have to mention in these patients itself. And you need to understand, delay and regression are not same. Delay kya hota hai? A particular milestone has not come. Regression is a milestone has been attained, but there is a loss of that milestone. So patients with mental retardation, cerebral palsy, some genetic syndrome will have developmental delay. On the other hand, patient with Rett syndrome, patients with leukodystrophies, they will have regression of the milestone happening. So your history should tell you whether it is delay or not, whether it is regression or not. Sometimes both can coexist. And details of developmental history need to be taken. Also, in all these patients, you need to take the antenatal, natal, postnatal histories in details. You also need to make a 3-generation pedigree chart. And always mention about presence of any seizures, presence of any muscle weakness, presence of any abnormal body movements, presence of any abnormal behavior, and presence of any poor responsiveness to light and sound. So always mention these points also. These are the negative histories that you need to take in these patients. You need to mention about all of this. They can ask you, why are you asking for seizures? We are asking for seizure because seizure will indicate that probably there is a focal lesion in the brain from where electrical discharge is happening. If it is muscle weakness, you need to mention about the muscle weakness. It can be upper motor neuron type, lower motor neuron type. Detail will come in examination, but here you need to at least mention that there is a less movements happening on this part of the body also when along with the developmental delay happening. Abnormal body movements are usually indicative of basal ganglia involvement in the patient. Abnormal behavior again indicates a cognitive dysfunction, and poor responsiveness to light and sound will indicate that probably your auditory and occipital cortex is also involved, or the pathways to them are also involved, right? So this CNS case, always ask about these histories. Motor weakness case. If you get a specific motor weakness case, always ask for whether it is a stiff limb but weakness or it is a flaccid limb weakness. If it is a flaccid weakness, your history or entire examination will go on the lines of acute flaccid paralysis. So AFP के ऊपर complete viva will go. This is one topic. You should be ready. Read it properly. कितना stool sample? What are the DDs? How will you distinguish between them? Very important. Stiff limb but weak will indicate usually a upper motor neuron cause, and upper motor neuron causes will be proximal to the anterior horn of spinal cord. So starting from the brain till entry into the spinal cord, these are the areas where lesion can be present in the patient. And whenever you get a motor weakness case, also ask about any family history. Why are we asking for any family history? Because many times there can be history of stroke in the families. Many times muscle weakness will be because of Duchenne's muscular dystrophy or Becker's muscular dystrophy, which are X-linked recessive condition. And so the maternal uncle will be affected in these patients. So Mama ji in the family will be affected. Mother will be carrier. Boy will be manifesting the disease. So there will be progressive weakness and all those calf hypertrophy and Gauer sign, etc. Weakness in getting up from sitting position. All those histories you will appropriately take in the patient. See, we do not have time for individual cases to discuss. If all of you are willing, and if we can squeeze in time in the next couple of days, I've requested Dr. Tutorials to just give me another 45 minutes or so, where I can discuss 7 or 8 sample actual cases. I will not go into the details of what I'm discussing here. It is a more general approach, right? So focused approach related to individual cases also I will be taking subsequently. So you can consider it as a part 2 of this video, but this part 1 video is the most essential one, and almost everyone is going to benefit directly or indirectly in the exam from the points which I am discussing here. Then if you have a respiratory case, you always ask about fever. If it is a fever present, think of an infectious cause. Fever is absent, think of a non-infectious cause. So non-infectious causes can be developmental respiratory problems. They can be congenital problems. They can be allergic conditions like asthma or cystic fibrosis in the patient. And respiratory symptoms, whenever you ask for, go into the details of the patient. Go into the details of the patient. When you ask about respiratory symptoms, what are the things you will ask for? You will ask for history of any cough. You will ask for history of any headache, because sinusitis can lead to headache in the patient. You will ask for any nasal block or nasal discharge. If cough is present, you will ask for whether it is productive or not. Whether you will ask for any, if productive is there, details of mucus will be present. Any blood is present in the cough or not. You will ask for any diurnal variation of the cough, aggravating and relieving factors. You will ask for any chest pain. You will ask for any rapid breathing noticed by the patients. You will not use the word tachypnea here. Tachypnea is the technical word. Parents will say tez saans. So rapid breathing. You will ask for any noisy breathing. Noisy breathing can be of 2 types. If it happens during sleep, it can happen due to adenoid hypertrophy. If it happens during awake state or any time, it can also happen due to stridor or wheezing in the patient. Whether it is stridor or wheeze, you will be able to make out only when you examine the patient. And you will ask for any associated bluish discoloration because of respiratory symptoms present or not. And you will ask for any features of distress. Parents will say the child is breathing fast since 2 days, and the child, when he breathes fast, he also has features. How will you ask for features of distress? The child will have flaring of nares, external nares, and there will be chest retractions or chest inroad. These will be the features of distress that you will mention in the patient. So details of these respiratory symptoms need to be mentioned. If you are suspecting asthma, I've already told you, always look for a positive family history. It may or may not be present. Positive family history is usually present in the family. And also, age more than 2 years. Do not think of bronchiolitis. Acute bronchiolitis. Acute bronchiolitis is caused by a respiratory syncytial virus. right? So ये जो acute bronchiolitis होता है, it always happens below 2 years. It is a febrile illness and the child has wheezing and respiratory distress. So do not think of bronchiolitis in a older child. Bronchiolitis obliterans अलग condition है, that is not related to the infectious part, the common part of bronchiolitis that we are talking about. Coming to abdominal case, many times you will get an abdominal case, you will get an abdominal mass, abdominal lump. So you will look at the location, what is the part of the abdomen where it is affected in the patient. So we'll look at the location. And when you mention location, don't use the word epigastric mass. The word epigastric mass will be used in examination. When you are mentioning a history, you will talk about upper part of abdomen, left side of abdomen, right side of abdomen, lower right side of abdomen, central part of abdomen around the umbilicus. These are the ways you will be mentioning. So do not use the 9 divisions in history, use them in examination. Very, very important point. Some examiners are very particular about it, right? Next is you will ask for fever in the patient. Fever, if with mass, will be infective. Without fever, you will think of non-infective causes. Ask for weight loss and loss of appetite. If present, you will think of malignancy as one of the differentials. So malignancy will be a differential diagnosis. Ask for whether it is painful or painless. Painful mass usually seen in inflammatory condition. Painless enlargement can occur in certain non-inflammatory conditions. And ask whether it is progressively enlarging or it is static in nature. The common masses that you will find in the patient, in case of infants with vomiting, they may have CHPS, they will have epigastric mass. You will not use the word epigastric, but it will indicate CHPS in the patient. You will say upper central part of abdomen. In case of age less than 2 years, painless mass, increasing in size, and associated with hematuria. And it is a unilateral on one side. Think of Wilms tumor as the likely reason. Another differential will be pyelonephritis. Although pyelonephritis will have tenderness, so yeah, painless mass will be ruled out from here. So Wilms tumor, if pain is present, think of pyelonephritis or a renal mass will be present, or a renal abscess or a perinephric abscess in the patient, in the child. And thirdly, in case it is a age should be 2 to 3 years. Age 2 to 3 years. And if it is age less than 1 year and similar mass, no hematuria, think of neuroblastoma as one possibility. So Wilms tumor, neuroblastoma, epigastric mass of CHPS, sometimes a non-specific mass due to some other malignancy or secondary metastasis, those can also present. But these are the usual points that you will look out for. Then when it comes to malnutrition patient, malnutrition case, the dietary history is very important and you need to go into the details of dietary history. So the ICMR chart reading will become mandatory here. Now, malnutrition can be due to nutritional causes. It can be due to some underlying illness like CCF, like cardiac disease, like respiratory illness, like a chronic metabolic disorder, like malignancy. So negative history of all systems need to be taken. And always take history of easy fatigability, because that will indicate the patient is having anemia or not. And you will also ask for other symptoms of micronutrient deficiencies. If present, you will mention them separately, elaborate on them separately. Usually, most patients, most children with Kwashiorkor marasmus will also have other micronutrient deficiencies. So details history of those, the difficulty to see in dark, easy bruisability or extensive bleeding due to vitamin K deficiency, and any easy fatigability, which will be due to iron deficiency. It can be due to B12 and folate deficiency. All these factors you will look out for. CCF can also be a feature of wet beriberi in the patient. So detailed negative history of all systems need to be taken, and you need to correlate with the specific finding with what is the location of the illness that is causing the disease. So these are some of the examples that I wanted to discuss, the points related to individual systems and cases in history. So we move into the world of examination. Now, when you take examination, when you perform examination, Just a minute. I'm also breathless talking non-stop. Just a minute. Just give me 1 minute, please. I hope all of you are understanding the points I'm discussing here. See, it is very difficult to take online history and examination class. I love to take it. I miss that feeling of, discussing with students in front of you in medical college kind of a setting. But some things, I've tried to incorporate the things which can be useful to you in a general way and which can potentially prevent your, loss of marks in the exam, and which will also be useful in you reaching the correct diagnosis. So there is something for everyone, but this is to be used in conjunction with whatever you know already and whatever you need to know. Specific case details and sample case scenarios, as I said, I will be planning in the next couple of days very shortly. And by tomorrow, you will get the details of that also. That will also be a shorter session, but a YouTube session. So let us talk about the examination. So points to note. But just like history, when you perform examination, you should always be performing the examination in adequate light. Don't do it in a closed environment. Preferably natural light should be used. If not possible, then normal light can be used. Normal tube light should be used. However, the use of those yellow colored bulbs should be avoided. If possible, take the child away from that, because interpretation of signs, icterus, etc. can be faulty in yellow light. So use white light where possible. Natural light is always the best. Take consent. Very, 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 very important. India के अंदर क्या है? There is no concept of consent. We assume कि patient is admitted in hospital, so we start examining the child. Sometimes we don't even introduce ourselves. We'll walk. You will see even some postgraduate residents do that. Some junior consultants also do that. It's a bad habit. It's a very bad habit. And don't learn bad things or wrong habits or wrong practices from your seniors. Inculcate the good things, but avoid the bad things. You may have a certain idol who has all the good things, but he smokes. So take the good things from him, but avoid the smoking part. So similarly, when you go to an examination hall, when you are examining the patient, be courteous, ask permission from the parents. It is their child. Take consent, introduce yourself, and tell them that this examination and history is going to benefit them. It is going to benefit us, but tell them that it is going to benefit them, because senior doctor will be coming and your child's treatment will be rechecked, that whether the child is getting a good treatment or not. Parents will be more than happy to help you out. If you take the parents into confidence, they themselves will help you out. And suppose you say a wrong thing in the exam, parents are smart enough. They will not say, no, isne nahi pucha tha. They will know that you are giving an exam and they will actually help you out. It has happened with me on a personal basis. I said a random thing. Then I realized the examiner looked at the parents and they asked him, back in my residency once upon a time in my life, the parents were good enough to tell. They said, yes, pucha tha. And they smiled at me later. I was like relieved at that time. Don't let that situation come, but take consent where possible, right? Expose the child appropriately. This is again very, very important. When I say expose the child, in your clinical manuals that you follow, you have Meherban Singh you are following, some are following Aruchami or Santosh Kumar. You will say it is mentioned that the child should be exposed. In an abdominal case, you should be checking for the genitalia. So what children will do is, what students will do is, they will undress the child. Don't do that. If you have to undress the child, first of all, take consent from the parents. Put up a screen. Every hospital has a screen which is there. Put up a screen. Privacy of the child is very important. Then only when you are performing actual examination, then remove the undergarments of the child. Whatever examination you have to do that, and then you put it back. Not that you're taking the history and you ask the parents to remove the entire garments of the child at that time, and the child for next 20 minutes he's like naked on the bed. That is wrong. That is unethical, and that is something that you should avoid. If somebody sees it, the parents will be irritated, the child will be irritated, and some examiner sees it, you're going to get negative credit for that. If you don't check for the genitalia examination, you get negative credit for that. Do it. Preferably Every case ideally has to, but practically has to be done in every abdominal case. Do it and then put the garments back on the child. This is again an important thing. Equipments to carry. See, the advice I'm giving will carry with you, and life is not only about exams. You have to be a good physician, good doctor also tomorrow. You may end up becoming an orthopedician, but still you will have some child in the family, and you may be examining the child. So the same rules will apply there also, right? अच्छा habit जो होता है उसका कोई reason नहीं होता है, but at the same time these are useful for your practicals exams also. So equipments to carry. Always carry your own stethoscope. Don't borrow it from somewhere. Torch. Don't use mobile phone light. Do not use it. Many examiners are very particular. They see you and they will immediately scold you if you are using a mobile phone torch. That is not appropriate. And mobile phone, especially in a sick child, you are distracting the child. Also, the light quality which is there, that is variable. Thirdly, mobile phone can transmit the infections to a child prone to infection also, right? Measuring inch tape, it should be a non-metallic one. Spatula for oral examination, clinical thermometer, developmental assessment tools, which will have those blue and red and green colored rings and blocks with you, a tuning fork, and cotton swabs should be taken. Any additional thing you can carry, that is a bonus, but these are the must carry equipments that you should take with you. Apart from that, patient should be on the left side, your left side. I've already told you. Now, kahan examine karna hai? If age of the child is below 3 months, including newborn, or age is more than 3 years, you examine in a lying down child on a supine position on a table. 3 to 12 months, you examine in mother's lap. Age 1 to 3 years, either you can check in mother's lap or in standing position. So what are the positions that you should be taking? Can be asked in your vivas also. How did you examine and what are the ages at which table pe litana hai and so on. And examination should be done at the time of examination itself. While taking history, you can keep an eye from the side. You can have a look at general behavior and how the child is. But detailed examination should always be done when the examination part comes. Now, sequence to follow again. You first start with GPE, then you go to head to toe, and then you go to system-wise examination. GPE, general physical examination, start with general assessment, then vitals, then anthropometry, general markers, and any other feature. Let us go into the details of these. So first of all, general physical examination. First, you do check for the general assessment in the child. In adult case, how do you start with general physical examination? You say patient is conscious, cooperative, well-oriented to time, place, and person. Adolescent child, you can't use similar words. Adolescent child, you can use similar words, but in a young child less than 10 years, you will not use conscious, cooperative, oriented to time, place, and person. You will say child is active, alert, and conscious. If the child is sleeping, if the child is lethargic, or the child is having any other problem, you will mention that. The child should be active, alert, consciousness. These are the things you will mention first. Then you will comment on the hydration status. The child appears to be hydrated, or the child is having sunken eyes and the skin appears to be, there are loose wrinkles present on the face and the abdomen of the child. So you will comment upon the hydration status, particularly GI case and malnutrition case. Then you will comment on any visible equipment attached to. Very, very important. Very important. Many times during the child will be admitted, child may be having a intravenous catheter inserted or a feeding tube inserted, or the child may be having bandage. You need to mention in the general assessment itself. You will take entire history well, examination well. Examiner in the end will tell you, you did well, but why did you not comment upon this bandage which the child is having here? And then you will realize, okay, I could have got good numbers, but now I will barely be passing only because I did not mention it. See, mentioning these points is important because it's like you driving. You're driving somewhere. You're having your driving license with you. You're not going to get any credit for that if somebody checks. But if somebody checks and you are not having the driving license, then you will be penalized for that. So similar, you have to comment upon these visible equipment things that are visible during examination. And you will also comment upon any visible deformity in the child. Many times, child will be lying and one of the limbs will be short, or the child will be having a trauma case. Surgery may be ho sakta hai, the child will be having visible bruising, or the child may have, sometimes you will have syndromic cases. एक तरफ ear नहीं होगा या small ear होगा. So you have to mention in the general assessment itself. Then we come to the vitals. In children, the second thing to talk about is the vitals. So pediatric and medicine, thoda sa variation is there. So vitals, you check for temperature. And where do you check for temperature? Either check in axilla or in oral cavity. Very young children, they have suck reflex. So you put thermometer in the mouth, they will try to suck and swallow. So in up to 3 to 6 months, we only take axillary temperature. Older child, either axilla or oral cavity can be used. No role of rectal temperature. Always remember that. No child likes a thermometer going in his rectum, and no child, no adult. Rectal temperature kahan use karte hain? In general, remember, either it is a dead person. So corpse, you can do that. Dead body, forensic medicine. Or very sick patient admitted in ICU where you want to check for core body temperature. Both the cases will not be given to you in final prof. And that is why you will either check in axilla or oral cavity. Never say eardrum, never say rectum. Right? Always remember it. Then you comment upon, you mention the temperature. Always mention the temperature in degree Celsius, not in Fahrenheit. Fahrenheit mein nahi karna hai, because examiners want you, even if the thermometer has reading in Fahrenheit, convert it into degree Celsius and mention it there. Examiners are fond of, by convention, they ask in degree Celsius. Some years back, before the MCI, MCI was dissolved, there used to be a training manual for consultants where practical assessment kaise karna hai. There, it used to be mentioned there. A temperature should preferably be mentioned in degree Celsius. It was mentioned as a rule book for the examiners. I read that book at once upon a time. So abhi wo book nahi aata hai. So temperature, you have to mention degree Celsius. Then we have pulse. In pulse, you will look at the peripheral pulse. Where did you check for? You will ask, tell about rate, rhythm, volume, character, any abnormal finding, dicrotic pulse, Bisfree's pulse, any radioradial or radiofemoral delay. These will be present in patients of coarctation of aorta, right? And types of coarctation also, they will vary. Some radioradial delay may be present in the preductal variety of coarctation. Then you will look at the respiratory rate. The respiratory rate is very important, because if respiratory rate is having tachypnea in the patient, that may be suggestive of pneumonia. Pneumonia is a possibility. So that is why you always mention about the respiratory rate in the patient and whether it is appropriate for that age or not. So here the Viva points will go in the direction of what are the age-wise respiratory rate. Less than 2 months, 60 per minute or more. 2 to 12 months, 50 per minute or more. 1 to 5 year, 40 per minute or more. Right? Then you will check upon the BP. And when you comment upon the BP, tell whether BP has been taken or not. Be honest. Be honest here. Honesty is the best policy. You say, sir, BP not taken. The examiner will say, why? You will say, sir, child is 2 years. I did not have the appropriate cuff size. If cuff size is there in the ward, you will ask for it. You will take the BP. If appropriate cuff size is not there, you will say, sir, appropriate cuff, the cuff hota hai na, sphygmomanometer ka, bandhne wala. That is not available, so I did not take. But if 2-year-old child, you say, sir, BP is 90 by 60. Examiner will say, did you take BP? You say, yes. Examiner then turns to the resident or the nursing staff. Is there cuff available? They say no. Immediately, you are doomed in the exam. So don't do that. Accept it. Even if BP cuff later kahin se prakat ho jata hai, it just appears out of somewhere. Examiner will simply say, you should have taken, but he will not penalize you. So be honest. Don't make up things and don't tell white lies in front of the examiner. They are too smart. They have seen a lot of people like you. You think you're smart. They have been doing this thing for years and years. So you cannot, outfox them. Don't try to do that. So BP, tell whether taken or not, and if appropriate cuff size is available or not, and check for the, as I said, check for the cuff size. Irrespective, they will ask you for the formulas for BP in children. So what are the 3 formulas that you need to remember? I have seen people often forget about it. Remember that normal systolic BP in a child is given by the formula 90 plus age in years multiplied by 2. 90 plus age in years multiplied by 2. Normal diastolic BP in a patient, in a child, will be 55 plus age in years multiplied by 2. And if systolic BP is less than 70 plus age in years multiplied by 2, you should suspect hypotension or shock in the patient. All the 3 points important. They can be asked in Viva also. They can be asked in your certain universities have the OSCE system. Certain universities have the that station system where a particular thing is kept, and there are questions related to this. These are very, very frequently asked, and they will be tomorrow useful for your clinical case scenarios, MCQs also, if you get difficult questions in INI CET type of exams. So remember these formulas and be honest regarding blood pressure measurement. Ways of checking blood pressure measurement: you have the auscultatory method, you have the flush method, you have oscillometric method, you have the palpatory method. Different methods theoretically padlo, they are the same as you did in medicine. Same knowledge you can work here also. Then we look at the capillary refill time in the patient. When it comes to capillary refill time, you will use the blanching method. So when I say blanching method, you will press the skin of the patient for about 5 seconds and then leave it and see how fast the flushing in that area, normally, the normal pink color comes back. Normally, if capillary refill time in a child, it is less than 2 seconds. Certain books write as less than 3 seconds, but American Heart Association guidelines say less than 2 seconds. However, if it is more than 3 seconds, 2 to 3 is borderline. That it indicates delayed capillary refill time. If it is 2 to 3 seconds, it can be normal or abnormal. Sometimes cold environment can produce slightly delayed capillary refill time. But if it is more than 3 seconds, it is always delayed capillary refill time, right? Then you check for SpO2 on room air. SpO2, if you have the pulse oximeter available, then you will check. And in a respiratory case, you have to mention in the patient if pulse oximeter present. And SpO2 on room air, it is mandatory. You can borrow from someone or you can carry your own in the wards. It is mandatory if it is a CVS or pulmonology case. It is mandatory. You have to mention. You will get additional credit in the question, in the marking for this. Then we come to anthropometry. Anthropometry is not paid much importance in the medicine part, but in pediatrics, it is a very, very important area. You will check for the weight of the child. So weighing scale will be there. You will check for the height of the child. If age of the child is less than 2 years, you will say it is length. Length, height same hota hai, but above 2 years, we use the word height in the patient. And then head circumference and chest circumference will be taken in age less than 18 months. MUAC, mid upper arm circumference, will be taken in age less than 5 years, and always do it in a standing child. Always check it in standing position. Examiners sometimes ask you, lekar dikhao, because they want to see standing position with arm on the side of the child. How you will see? You will ask the child or make the child stand or ask the mother to support the child while he's standing. Then arm should be by the side. It should not be elevated. Many people, many students, what they do is they wrongly check for MUAC. How they will check for? They will take the arm like this and put it here. Wrong. Arm should be on the side. Come to that side. First palpate acromion process here. Palpate olecranon process here. Arm by the side. Check for using measuring tape the total length. Suppose it is 30. Moderate malnutrition below 11.5 is severe malnutrition. And what is the modification of this? You will say Shakir tape. They can Viva will go in that direction, and they can ask you MUAC for age classification is called as which classification? MUAC classification is also called as Arnold classification. So if you have a malnutrition case, you may get possibility of Arnold classification being asked in the exam. Here I'm writing For practicals, please note it down. For practicals, if you get a malnutrition case, what are the classifications you are supposed to remember? You will remember about the WHO classification is important. That will be asked in your exam. You will remember IAP classification. You will remember Gomez classification. They're not useful for theory, like in Viva, Grand Viva as well as table case Viva, you will be asked. Fourth, you need to know about Waterloo classification. Fifth, you need to know about Wellcome Trust classification. When I mention this list, people get afraid. Sir, itna classification? This is bare minimum. There are more classifications than this. Sixth is Arnold classification. These 6 classifications they have to be read. The differences between them, you need to keep them ready. So they have to be read in the patient. So these are the 6 malnutrition cases. Additional you find in your practical manual, you remember it, it is fine. And you should be calculating, you should know the formula BMI for age. If obesity is suspected, obesity or overweight child, you will check for BMI for age. Younger children, malnutrition cases, this is not mandatory. Plot each value on appropriate chart and be ready with the interpretation. Whether the child is having reduced weight for age, if the child is having decreased weight for age, below 80% of expected, you will say the child is having underweight child. If the child is having reduced weight for height, below -2 standard deviation, you say the child is having wasting. Wasting indicates acute malnutrition in the child. If it is below -3 standard deviation, we use the word severe wasting. If then you check for height for age. If height for age is below -2 standard deviation or -2 Z-score, we use the word stunting. And if it is below -3 standard deviation, we use the word severe stunting in the patient. So this is almost a sure thing for your exam. Sure thing. Every second student will be asked about it. Wasting indicates acute malnutrition in the child. PEM is protein energy malnutrition. This indicates chronic PEM. And underweight child can be either acute or chronic. It cannot distinguish the two. Very, very important. If possible, just pause for a minute, take a snapshot. I also catch my breath. Take a snapshot, or you can take later on, so this will go on the YouTube channel. But ye do cheez padh ke jana hai. And when this thing is asked in the exam and you answer it confidently, then you will remember me. And if they ask you and you do not revise it, then also you will remember me. One in a pleasant way, another in a non-pleasant way. Let's continue. So this is about our anthropometry. Then we come to the general markers in the patient. So the next thing that will be asked to you in the exam is, where will you check for these findings in the patient? Where will you check for these specific findings? So 6 things you will check for in every child. You will check for pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. JVP, ideally it should be checked, but in young children, because of short neck, you may not always be able to see. So you need to mention about these things. Each point when you mention, if it is positive, the examiner will ask you to demonstrate it. Even if it is negative, they will ask you, where did you look out for? So when you check for pallor, what are the areas you will look for pallor? You will look for the lower palpebral conjunctiva. You will check for the lower palpebral conjunctiva. You will look at the dorsum of the tongue. Dorsum of the tongue, right? You will check on the oral mucosa. You will check on palmar creases. Plantar creases also you can see, but bachcho mein mushkil hota hai. So palmar creases, and you can also check for in the generalized skin in the patient. You will look for generalized skin in the patient, right? Usually interpretation between moderate and severe pallor, how do you make it? It is very easy to do. In case, now listen to me very carefully. In general, in pediatrics, what we say is any patient who's having paleness in the oral mucosa or lower palpebral conjunctiva, but the skin creases are pink. So this is pink, this is pale, this is pale, this is pink. You will say moderate pallor. But if everything is pale, the skin creases become pale, we call it as severe pallor. Always remember. This is not applicable in case of adults, but a child anyways is not a miniature adult. So remember that in case of young children, if skin creases are also showing pallor, it is always considered to be a severe pallor in the patient. Pallor first initially dikhta kahan hai? It is seen in the lower palpebral conjunctiva, right? First thing. Second thing, they will ask you details about anemias and all HP cutoffs. So those are the theoretical points. Then we come to icterus. When we check for icterus, it should be ideally be checked in the natural light and it should be checked in the upper part of sclera. Sclera, because it is white in color, why we check in sclera? Again, frequently asked question. We check in sclera because upper part of sclera, because first of all, it is white in color. You lift it and see. Second, it has elastin pigments, elastin fibers, which have a tendency to bind bilirubin, and so it early appears in upper part of sclera, right? Second question, which will be asked to you in the Viva is, when does clinical icterus appears in jaundice? In adult, it appears when total serum bilirubin exceeds 2 to 3 milligram per deciliter, but in a newborn and infant less than 3 months, it will appear when the serum bilirubin exceeds 5 milligram per deciliter. So two different cutoffs you need to remember. So it appears, I'm writing for those who don't know, appears in adults and older children when total serum bilirubin or simply serum bilirubin is more than 2 to 3 milligrams per deciliter. In case of newborns and young infants, it appears when serum bilirubin exceeds 5 milligram per deciliter. So very important point. Every second person in pediatrics will be asked this point. Third thing to check in these patients is cyanosis. So you check for cyanosis in the patient, and cyanosis you will check in the nail beds also, in the peripheries also, and you will check in the lips and oral mucosa also. This will tell you about the central cyanosis. This will tell about the peripheral cyanosis, right? Fourth will be clubbing. The grades of clubbing you need to remember. The same grades of clubbing that you read in medicine will be applicable here also. Same causes of clubbing which you read in medicine will be applicable in pediatrics also. Then we check for lymphadenopathy. Very, very important, difficult thing. How to palpate the various types of lymph nodes that you need to practice in the clinics and wards before the exam. So how you check, from where you start, what were the areas, how do you check for axillary, anterior axillary, how you check for posterior axillary. See, when you are checking for anterior axillary and central axillary, you are sitting in the front. But when you are checking for posterior axillary, you are coming from the back and arm position should be like this. So the arm position and how you check, very important. Please practice. Tomorrow, make it a point, or tonight, go to the ward, catch hold of your senior postgraduate resident in the wards, if you are staying in a medical college, and ask him, jolt him, tell me please how to do lymphadenopathy. Don't go for first year MD residents. First year MD residents are, in any branch, they're useless. They are useless because they have cracked the exam, they have forgotten what they had done during passing their final exam, but new skills they have not acquired. So they are in a very twilight zone. It is the second year residents and third year residents or the interns who have passed who will tell you more reliable things, right? So that is why I always joke. I have passed through that phase, but usually first year residents who hote hain, they are the ones who are always, bullied by their seniors. They are the ones who themselves then bully the interns, and you look at them and you're like, wow, but they are not having a very brilliant time of their life. First year of any residency is always difficult, especially in pediatrics. But end of the day, by the time time passes, they acquire new skills, and the first 2 years of the residency is the time where you actually develop the skills which are going to last you for a long time, right? So empathize with them, but they may not be that good to tell you about the exact way to palpate. Then significant lymphadenopathy किसको कहते हैं? Again, it is very controversial. It varies according to the age. The values which you remember for adults, they are also applicable in children. However, there are some exceptions to this. So that is a theoretical point. Most of the clinical manuals have those points mentioned over there. Then we'll check for edema in the patient. Edema, where do you check for? We press for 30 seconds on the medial malleolus or anterior tibia, and you mention upon whether it is edema, which is bilateral or unilateral, it is pitting or non-pitting, and you make the adjustment accordingly. And then jugular venous pressure, you will mention if you are able to see, if you are able to calculate the jugular venous pressure in the patient. Just a minute, please. There is an interruption. Yes. Can you see me and hear me? Please confirm. There was a slight interruption because somebody was calling me. Can you see and hear me? Please confirm once. We are almost there. Just 5-10 minutes ka class reh gaya. So just stay with me for another 5 to 10 minutes. Yes, no. Can you hear me? Can you see me? So I will continue. Okay, thank you, Saina. So we continue. Thank you, Sri. Thank you. So after this examination, we have to perform the head-to-toe examination. Now, head-to-toe examination basically means that you start from the head and go till the foot of the child. In head-to-toe examination, you need to perform in every child, but details to be mentioned only in a neonatal case or a suspected syndromic or malformation case. Let me give you a scenario. What do I mean by this? There is one patient who is having nephrotic syndrome or fever with rash child, 7-year-old. In this child, after the initial part of general physical examination, you will say, sir, I also, or ma'am, I also performed head-to-toe examination, but it is apparently not. You will mention that you did, but you will not go into the details. Suppose there is a child who's having nephrotic syndrome, but he's also having a polydactyly. So you will say, sir or ma'am, I performed head-to-toe examination during which I found that this patient is having polydactyly. You will mention what type of polydactyly. You know Hrithik Roshan? Hrithik Roshan has extra digit on the attached to thumb. So something which is attached here on this aspect is called as pre-axial polydactyly. Something present beyond this on the ulnar aspect is called as post-axial polydactyly. So you will say polydactyly is present and whether it is pre-axial or post-axial. Remaining head-to-toe examination is normal. So you need to check the child. You will ask the parents also during history, then you will check during examination also that you're not missing out on something. Young infants or newborns will have some discoloration of the skin called as Mongolian spots on their back. You will mention it in head-to-toe examination. Certain children, they will have, some abnormality, certain, as I said, small dysplastic here. So you will mention in head-to-toe examination. You will mention initially, you will mention in head-to-toe examination also. When you mention in head-to-toe, you will ask about the details, that it is small in size, this is the dimension, compared to the other size, it appears to be dysplastic and small in size, right? So head-to-toe examination, in a young case, syndromic case, you need to mention separately, head is normal, eyes are normal, no abnormal facies, no epicanthal folds, no low set ears. Low set ear we look for by making a line like this, you know already in Down syndrome. No neck skin tags, no webbing of the neck, no polydactyly, no abnormalities in hand and feet, no herniation, and so on. So examination wise, head-to-toe was. If it is abnormal, you miss out, you lose. Thinking of a cardiac case and you start doing CNS examination, that is wrong. So first, a relevant system needs to be discussed in detail, inspection, palpation, percussion, auscultation. Finish it off. Then you move to the next step system. If the other systems are not relevant, simply say in a cardiovascular case, other examination findings were normal. Remaining systems like respiratory, GIT, or per abdomen examination, CNS examination, musculoskeletal examination were within normal limits. It is up to the examiner whether he or she wants you to perform a particular test or not. But the system in detail you have to mention. Details of only the relevant system, as I have already told you. And when you perform this examination, you should know the signs involved, and any sign you mention to be positive, examiner will ask you, examiner asks you to perform. So be ready for it. Anything you say it is positive, examiner will say, show me or elicit in front of me. So be ready for it. So wahi bolna hai which you can elicit. You have read something, somebody has told you, don't fall for it. It will be a trap you will be walking into. After this entire examination has been done, you have to now summarize the examination findings. Here also, you will mention the key points. So how you will summarize? Sir, examination summary is as follows. On examination, the general parameters of the child were fine. The vitals were stable. The child had the anthropometry was normal. However, the child had weight for age, which was 71% of expected, and underweight child was there. However, the other parameters were within normal limit. So some degree of malnutrition is there in the child. In addition, the child also had some pallor, but remaining findings were normal, and systemic examination was also absolutely fine. So this is how you will summarize the finding. In case of provisional diagnosis, now you will combine history and examination finding. How? In a cardiovascular case, you will say, sir, how you will summarize. Sir, this is a 6-month-old child who has presented with feeding difficulties, poor gain of weight and length, and this child is also having features of other micronutrient deficiencies. On history, on examination, I noticed that the child was having some tachycardia, but the remaining examination was normal. The general examination was normal. The child had some features of wasting as well as stunting present. Also, I found that this child is having a systolic murmur present with no radiation, and this is the grade of the murmur. So this child is likely to have a cardiovascular involvement. There is a likely left to right shunt with a murmur with features of malnutrition. So examiner will ask you which cardiac condition you are suspecting. You will say, sir, acyanotic disease with left to right shunt. In this age, likely to be ventricular septal defect. And we will immediately pass in that exam. Make it a point. When you mention provisional diagnosis, you mention about the system involved. You mention about the likely etiology. You mention about the clinical possibilities. What other possibilities can be there? Agar fever with rash hoga, to multiple possibilities can be there. Viral illness, this, that. You will mention those, and you will always comment on protein energy malnutrition present or not. Every case. And how will you comment upon? Based upon anthropometry. And if it is present, what grade of malnutrition is present according to which classification? You have to mention it there, right? And in case it is a cardiovascular case, additional thing to mention. Additionally, always mention about if this patient is having CCF or not. In case of renal case, always mention whether the patient has been started on medication or not. If the patient is on steroids, the patient may already be improving by this time. So that fact needs to be mentioned in the summary finding. You would have mentioned it in the initial part also, treatment history, but you will mention it here also. Don't miss it out. Things these are often missed in the patient, right? And these are the clinical possibilities. Many times, what will happen is everything is fine, but you cannot localize. So you will now your viva will be entirely theoretical. It's absolutely fine. How you perform the examination, you get credit for that. Very early in your 10th standard board exams, mathematic questions. Sometimes your calculation will go wrong, but the steps you have taken, you will get credit for that. Same thing happens in these case scenarios also. And how examiner will then ask you, how will you proceed next? You will say, sir, I would like to investigate the patient. And they will ask you, what are the investigations you will do? Now it will always be a theoretical viva that will continue. How will you manage this child? So treatment, investigation to perform, that all will happen. However, if it is a protein energy malnutrition case, if it is a PEM case, in these patients, you will need to talk about nutritional rehabilitation. And this is where two things Viva will go into. One thing, what is SAM management? SAM management is severe acute malnutrition management. दो तरह से होता है, at home or in hospital. So you have tables given in the theory book. You need to go through them. And secondly, what are the calorie protein requirement of common food items? How will you chart? What are the things you should be mentioning? So that is again ICMR data, ICMR table will come handy here. So you need to prepare this type of questions pre-hand before you go for the exam. How you are going to proceed, how much calories are chapati has, how many calories arhar dal has or a tur dal has. So those you need to see and those you need to incorporate. Glass of cow's milk has how many calories, buffalo milk has how many calories, whether it is a cup of 100 ml or it is a 200 ml glass that you are using, those things you need to practice. So if time permits, if logical, I will try to arrange one of the example of that case in the subsequent interaction. And in the end, what are the systemic examination things students are often asked to perform? Please practice them in the wards or clinics. Sometimes your name starts with Z. You're the last person. An examiner is tired of taking the viva. All he's interested in is, now I go to hotel and I chill. So he will ask you your name and he will ask you, what is your case? You will say, sir, CNS case. So you will simply say, tell me the summary. You tell the summary. He will say, okay, perform the meningeal sign and go. Now your pass and fail depends upon you can perform meningeal signs or not. So that is why certain examination findings are often asked to students. What are these? You should practice in wards before you go for the actual exam. How to check for cranial nerves in a child. How and when to do meningeal sign. Remember, less than 18 months, less than 18 to 24 months, meningeal signs are negative. So you don't perform them. Above them, they can be positive in a child with meningitis or meningoencephalitis. So we watch for Kernig sign, Brudzinski sign, nuchal rigidity. These are the three signs you look for. Nuchal rigidity, in a sitting position, ask the child to touch his chin to the chest. Kernig and Brudzinski sign done in a lying down child. In one, you lift the neck of the child, another, you lift the leg of the child. Where you are lifting leg, where you are lifting neck, that you need to be thorough. Then how will you check for liver span? First, you palpate the liver, mark the lower border. Then in the right mid clavicular line, you start tapping wherever you will find dullness coming. That part will be your liver span. So don't mention about hepatomegaly in children directly, because how many times children, due to vitamin D deficiency, rickets also, they can have slightly moving of the abdominal organs on the lower side, particularly in a standing position. So liver span is a better marker in suspected hepatomegaly. Then we check for techniques to palpate liver and spleen. What is dipping method? What is palpatory method? In ascites, how will you check for single hand, two finger or dipping method? The usual techniques which you read, medicine mein, pediatrics mein, very important. They will be useful. They are also asked in details in medicine. So be ready with that in pediatrics also. Rules are the same. Where to look for renal angle tenderness? You look at the back. How you demonstrate that? Examiner will often ask you. If it is a CNS case, they will often ask you to perform deep tendon reflexes and their interpretation with grading. Grading of reflexes, there is a table given in the clinical manuals. Remember that grading is also called as MRC grading. Then how to calculate dietary calories and proteins. I've already told you. You need to remember from ICMR. How to nutritionally rehabilitate a child. I just told you. How to perform cerebellar signs. Cerebellar signs, again, very important. What are the cerebellar signs? How will you perform them? So ataxia, dysdiadochokinesia, finger nose test, walking in a straight line test, Romberg sign, all these signs very important in medicine as well as pediatrics. How to check for muscle power, upper limb separately, lower limb separately, flexor, extensor separately, abduction, adduction separately, you need to mention. Always comment on genitalia and hernia status during abdominal examination. According to the older MCI guidelines, there was 0.5 positive credit for this, 0.5 positive credit for checking and mentioning in the examination. So if you are not mentioning this, you're losing on one number. Every number, every drop matters in the exam. Then you palpate the abdominal mass and describe. How will you describe the abdominal mass? You need to prepare. And how to check for ascites, the test you perform to check for ascites in the patient, the puddle sign, the shifting dullness sign, fluid shifting, all these signs you need to check and perform in the patient. So this is about history and examination. In pediatrics, it is tricky. The way you proceed, the way you perform the signs, informant, correct sequence, positive history you are taking, developmental history you took or not, whether you took family history and made the pedigree chart or not, dietary history you took or not, very important. In the examination part, anthropometry, its interpretation, summary of history, summary of examination, and provisional diagnosis based upon them, detailed examination of the system, other systems, only superficial examination you need to mention. If you do it properly, even if you are unable to make the diagnosis, still you will pass the exam. In case of long case, you need to go into detail. Sometimes long cases will be clubbed into short case. In short case, you do not need to go into the entire detail. You only, in history, you only talk about the positive complaints and you mention any positive finding in the nutritional history, dietary history, etc. Other than that, you simply say normal. In examination, you only mention the positive findings, malnutrition part, and then talk about the relevant system alone. You don't go into the details. It has to be a compact case. It has to be a focused case, right? So some examples of long case and short case and nutritional rehabilitation. Next couple of days, I will be announcing a small session. You can attend that. And this file has been given to you. In case you don't have this file, do let me know. And do stay in touch after the exam is done. If you benefit from this, do let me know. But end of the day, at least 2 to 3 visits you have to make. Go to pediatric ward, see the files, see the finding, perform these signs, especially the signs which I mentioned, and you will be, ready. Don't be afraid of the patient, but follow the procedure. That is right. I hope you all benefit out of it. So I was asked to take strictly within 2 hours. It is 2 hours 15 minutes according to the time I started. All the best, everyone. And जो लोग ये बाद में देखेंगे, you can recommend it to your juniors also later. So it is a summary video. It is not a detailed video. It is a summary video. I hope you benefit out of it. So thank you very much. Any doubts? Any things you want me to add? Any comments? Any positive thing? Any negative thing? Negative thing, I'll feel bad, but it's okay. You have the right to say. It's a free country. So some of you are disappearing from the live chat. The number of people are disappearing. It's okay. Every minute matters. So do let me know. Okay. So you're welcome, Sukhi. Welcome, Tiny World Explorer. And all the best for your exam. Bye-bye. Another small session I'll plan very shortly, preferably before you sit for the exam. Thank you very much. Thank you. Thank you. Thank you.